Hello everyone. It's good to have you with us. Welcome to this late afternoon symposium sponsored by Abbott. We have a great panel. Let me introduce my colleagues, Von Kim from Bad Nauheim, Fabian Dietlisbach from Switzerland, Dave Smith, and Danny Dwyer. My name is Leonard Conradi. The topic of today's symposium will be hemodynamic performance of aortic valves and a few considerations around the topic. And what we would like to do and ask you is to make this interactive. I know everyone's saying this, but we have really reduced the number of slides. We do not want this to be a one-directed, presentation type kind of symposium. We really ask you to ask your questions, raise your hands, interrupt speakers, whatever you feel appropriate. Let's go to the session learning objectives. What we want to do is try to understand why hemodynamic performance and patient prosthesis mismatch impacts valve durability, and by that maybe patient survival. We want to learn how to appreciate how the design of bioprosthetic valve influences outcomes. And finally, we will topic paravalvular leakage, and again with regard to patient outcomes. And the make of the symposium is such that we will open with a case, then tackle a few topics, hand it back and forth between my esteemed colleagues here to discuss, and with you hopefully, and then come back to the case later on and see how we decided to treat. So without further ado, I'll start into the case presentation. These are my conflicts of interest. This is a 70-year-old female patient. She is maybe a little bit on the heavy-set side, not really. She's severely symptomatic, no coronary disease. She does have a typical, cardiovascular risk profile. Comorbidities, little hypothyroidism, status post bilateral knee replacement. She is mobile, but somewhat reduced in her overall mobility. You can see the formal risk stratification down there. So just formally speaking, this is actually a low-risk patient and maybe on the young side. This is her baseline echo, explaining her NYHA status, preserved biventricular function, but severe tricuspid aortic stenosis. You can see opening areas, gradients here. See, she has a concomitant or combined valve dysfunction, if you so will, with mild aortic regurgitation. We subject all of these patients, regardless of which way we want to go, surgery or intervention, to CT. I think you have to do this. It's even useful for surgery if you decide to do so. And what we found was that her annulus was somehow on the small side, if you so will, by parameter. This was just above 22 millimeters. LVOT correspondingly close to 23 millimeters. This is the view on the valve itself, mild, maybe moderate valvular calcification. There is some calcification extending to the subannular region, so some LVOT calcification. These are some planning images, should we decide for a transcatheter valve. And of course, we'll have to assess the iliofemoral anatomy, heart to skin, so start where you might puncture and end where you might land with the valve. So in a nutshell, this case is a patient with an anticipated longish life expectancy, but a small annulus. And within the next hour or so, we'll have to decide what we think should be considered and what are important considerations. And with that, I'd like to hand over to Dave to start us off with the discussion. Dave.
Brilliant. Thanks, Leonard. So, great case, lots to discuss. Perhaps the first thing to say is what we need to think about instead of a single procedure is clearly the lifetime management of a younger patient. And if we're not doing that currently, we will be in the very near future. So who do we need to worry about in terms of early valve failure? So these are my relevant conflicts for the talk. Now, clearly, we do have a way of quantifying prosthesis-patient mismatch. So essentially, we've known for many a year from the surgical data that when we do have PPM, we essentially have a valve that's too small for the patient's body size, and the consequence of that is to leave higher than expected gradients through a normally functioning valve. And as you can see from the color chart there, we have a way of quantifying this, so we can bear this in mind throughout this presentation. Now, we also know from the surgical data, and this, as you see from this, dates back over the last 8 years, that PPM is associated with both premature valve degeneration So clearly we want to avoid it. And equally, we know that if you have severe PPM, it's actually associated with cardiac mortality. That's all very well and good, you may say, but we're in a TAVI era and we're discussing TAVI in preference to SAVR in many of the cases we undertake these days. Well, here's the TAVI data. And this is from the TVT registry published 4 years ago. And we can see here a high instance of severe patient prosthesis mismatch, this time in the gray portion of the pie chart. And already at 12 months, this is associated with, wait for it, mortality. So clearly we have a need to avoid severe patient prosthesis mismatch. This is data I presented yesterday. This is the new contemporary Navitor valve, and this is divided by valve size. And you can see that now we have in blue mean gradients and in red effective orifice areas. And you can see we're now in an era where we've got options, despite the size of valve, to achieve excellent hemodynamics. And this is the consequence we see from this data in terms of patient prosthesis mismatch. And this is related to annular diameter. And you can see in the small diameters, we actually had no patient prosthesis mismatch in the 37 patients we've studied, and a very small proportion, 3.2%, in those with larger diameters. So we have now the tools to take on the job. So I'm going to sort of ask Fabian, if I may start with from what we've discussed, who are the people who we need to be looking out for?
Well, it's already been mentioned. In the old days when TAVI started, we were just happy to put the valve in, and we were happy if there wasn't too much paravalvular leak. And despite the fact that we were focusing on these two issues and we wanted to avoid any type of annular damage, be it through balloon valvuloplasty or through the valve itself, these were the main goals. Well, nowadays it has changed. We have so many good valves, so we want to be perfect. And we already know that despite the fact that we cannot do root enlargement as surgeons can, hemodynamically, TAVI valves are doing better than surgical valves. Now, in small annuli or in young patients, this becomes particularly important, and we want to be perfect. I think, therefore, a gradient that's 4 millimeters of mercury higher in one valve than in another valve, or in one patient than in another patient, plays a big role. And while before you had a calcified chunk of calcium, and you just wanted to make that valve as big as possible, now with the sealing cuffs, you think, okay, paravalvular leak is not an issue, but don't then just compromise on gradients, because you think the sealing cuff is going to deal with the paravalvular leak. So do not compromise and go for as low gradients as you can, particularly in small annuli and in young patients that may require a second procedure anyhow, but you can avoid maybe a third one.
Yeah, it's a good point, isn't it? So younger patients with smaller annular anatomy. And I might just bring Leonard in this as well. We often hear about the potential option of root enlargement. Is that a frequent occurrence?
It's an excellent question. You know, we just had that discussion in the main arena in the previous session, and I was surprised to see a lot of hands go up in the auditorium when we asked, are your surgeons actually doing it? Because certainly in my personal experience, in the German perspective, I think it's vastly underutilized. And I think it may be a little bit in parallel to a learning career. Fabian, you said that we had a learning career with TAVR in that, first of all, we were glad not to harm the patient. I'm exaggerating a little bit. To today, where we're thinking towards the end of his lifetime, to the end of his journey. And a little bit the same was true with surgery. In surgery, the nearest thing was give the patient a safe procedure, and if in doubt, run away with a small valve. This is not enough, and I have to say, interventional cardiologists have really woken up the surgical community, and I'm glad to see young physicians, young surgical colleagues, more and more interested in these techniques. Now, I don't know if you've seen this brilliant presentation by Hendrik just now, who did this in a minimally invasive fashion, 5-centimeter skin incision. This is really top-notch surgery, and no, not everyone, you should not be intimidated by this. You don't have to start like this, but there's enough opportunity to do this in open cases, combined surgeries, or even via full sternotomy. I think the overarching aim is avoid PPM regardless of the type of procedure. Danny, what are your thoughts about this?
No, absolutely, but it goes to the fact that we do not have enough surgical practice now in the aortic field in order to have enough people getting experience in challenging procedures. And usually if you have a challenging procedure, then the senior person will be the one that is doing it. So it's not easy probably to train for these kind of procedures, but obviously the word is out. We know now that hemodynamics matter. We know that for decades, and it slowly but surely goes also to the interventional community, that effective orifice area, low grade, that should be as large as we can to minimize the risk for prosthesis-patient mismatch. And you know, it's not only to have good results at baseline, without activity. What happens to the valve when you are active, right? We're talking about treating patients that are younger. In a second, we will do the majority of patients in the 60s with transcatheter tools. What happens to a 65-year-old when you have a valve with a mean gradient of 12, which is a relatively common scenario? What happens when that patient is exercising? Maybe it's not enough when it will be higher.
Absolutely. Yeah. So Von, I know that you have an absolutely intact heart team in Bad Nauheim. Can you comment is there an increasing importance of hemodynamic considerations when choosing procedure type, or is it still basically risk adjudication?
This is a very good question. We have a very good heart team. And but to be honest, the primary driver of heart team decision is still it's still based on other aspects and not on hemodynamic factors. And I absolutely agree that at least in Germany that root enlargement is underutilized. And I think what you have seen in the main arena might be some selection bias of those surgeons that are very interested in interventional aspects as well. So,
but can we agree that in a time where the primary driver pro TAVR is not risk alone, but is increasingly becoming life expectancy, lifetime management considerations, that hemodynamics play an increasingly important role in this, or Absolutely. Are there other voices? Yeah.
Yeah, hemodynamics in several aspects. I think, also in terms of sizing. If you say, okay, I want to put in an as big valve as possible just to have low gradients, and then you oversize the valve. Maybe you get earlier degeneration because of the leaflets that are not naturally expanded as they should. So if you end up with a procedure, it should be with a mean gradient in single digits,
or is it not?
But also sizing should be appropriate. So don't compromise in either or the other direction.
Very good.
It's a very good point, isn't it, about compromise. Normally we have to compromise something, whether we have to compromise hemodynamics for perhaps coronary access or perhaps pacing rate or conduction disturbance. And there's a good question just come through, actually, just asking, why is it that these younger patients have a higher risk of valve failure? The question says, is it because of congenital factors, or do we not have the right valve size, or are there other factors that would cause failure in this group? So who wants to take that? Danny, do you want to sort of answer
the question whether patients with, let me take it correctly, whether patients with severe prosthetic patient mismatch, why do they have early failures? This is what
I think it's asking, why is it that the younger patients in particular are more prone to premature valve failure?
This is a very difficult question to answer. So obviously, we all understand that there is some kind of bias in which younger people would be more prone to have re-intervention than old people. Many of the old people will never get re-intervened. even if their valve is failing. There is under evaluation of older people. But even if we take it out, and there are many studies that are trying to take out that bias, we do understand that younger people get more structural valve degeneration. It could be related to physical activity, being more active. It could be that the immune system of younger people is different than older people, or a combination of these two risks. Yeah.
Great. So I think we'll have to move on. And before we do so, just on an anecdotal note, I remember that when I trained, someone said there are 3 rules for aortic valve replacement surgery. Don't oversize, don't oversize, don't oversize. You know,
easy
nowadays
to
it seems strange that these rules should exist, but this is avoidance of complications, as opposed to, you know, giving the patient an ideal result. But anyways, so we'll have to move on to the next a bit of this symposium, and I think we all agree that gradients and patient prosthesis mismatch play an important role, and there is, you know, the common conception out that the valve design, and I'm talking supraannular versus intraannular valve design, impacts this. You know, the basic hemodynamic or physiological idea is if you place the valve substitute at the location where the diameter is smallest, which typically is the aortic annulus, you will end up with a smaller valve, you will end up with a higher gradient, where as opposed to a supraannular valve maybe, where you put the functioning portion of your valve substitute above, above the aortic annulus, you might end up with a better gradient. And with some of the, you know, more conventional valves, this may be true. On the other hand, there may be more to it, and I think with the Navitor valve, we're seeing early signals. I'm very careful here because these are early signals that there might be a little more to that. Look at these valves from a side view. The Navitor is a cylindrical valve. It's a cylindrical valve stent. This has implications for its implantability. I think it has implications for its tendency to migrate or not to migrate. And compared to that, look at the Evolute in the middle. This is a tapered stent design. You may, or many of you will know how it behaves once it opposes in the annulus. And then the Sapien, where you could say, well, this is also a cylindrical valve design, but if you take another perspective here, there is a different angle to this where valve leaflet attachment obviously also plays a role in the effective orifice area that might be achievable with these valves. Now, I immediately agree that this is hypothetical, that we don't really have a whole solid data set to back this up. But when we prepared this, I was reminded of a study that our group published last year. And this is, again, very carefully speaking, retrospective, purely observational. This is non-controlled for things like the amount or distribution of calcium. It's not controlled for LV function. It's not controlled for baseline gradient. But this is choice of THV in small annuli, meaning below 23 millimeters. And if you look at this, the Portico, which was the predecessor and in some degree comparable to the Navitor, ended up with the lowest incidence of severe patient prosthesis mismatch in under 5% of cases. So even this has enormous limitations, which I tried to convey in the beginning. This is somewhat of a signal in order to break maybe a little bit with the supraannular versus intraannular binary assumption. And this is taking it to another route. Also, we're talking not just acute results, not just acute hemodynamics, we're talking lifetime management. And the two concepts to the left, where TAV and TAV, intraannular and intraannular, may be physiologically or procedurally more feasible, there might be a question mark here if you have a landing zone that is already, used up a little bit with the supraannular valve design. So there are two components to this part of the discussion, and I'd like to hear your thoughts, Dave. Do you think I'm making up a crazy story, or is there something that we're seeing?
No, obviously it's such a complex field, right? It's so different than what we used to think 5 years ago. How much should we oversize? How do we use CT for TAVR procedures, looking perimeter area? We were so basic a couple of years ago. We didn't really think about many concepts that we do think about them right now. But you started to bring a new concept of what should we do when our TAVR valve will fail. How should we treat it, right? It's is it easy to treat it? Is it complex? Is it something that will be a very quick and easy procedure, or is it maybe a procedure that will require a double basilica suddenly, or something that will be very traumatic for a patient, maybe even to send the patient to surgery, to open heart surgery? These are things that may happen. We always need to think about the future, about 5 years ahead, 10 years ahead, 15 years ahead, especially when we're talking about treating patients in their 60s.
Absolutely. So Von, what's your take on this? You have vast experience with different valve types, supraannular, intraannular, stent designs, whatnot. What's your take on this, basically?
Yeah, looking at the data we contributed to the analysis, I was very surprised, and also looking at the side view, and I really wasn't aware of it, that the portico has such a good hemodynamic feature. So hemodynamics really plays an important role, and this is especially important in patients with small anatomy. I think there's a missing link with how hemodynamics translates into long-term outcomes, especially in the TAVI situation. We need more long-term data. What we are talking about is based on assumptions, right? Yeah, we assume that there might be a higher risk of leaflet thrombosis and early degeneration. But I think even though we do not have evidence right now, we have learned from the surgical populations, and I think if we can make a decision on that during the implantation, we should try to avoid prosthesis mismatch. If you can do it, why not?
Absolutely. Fabian, what do you think?
Well, you know, what you brought up at the end, you know, I don't know anything about the mechanism of hemodynamics. What you showed, that the hemodynamics of the Navitor valve seems to be very good. But what you brought up at the end is coronary access. And to me, this is absolutely crucial if you think about lifetime management of a patient. And therefore, there is a huge advantage of a intraannular valve as opposed to supraannular. We see now patients coming back with different TAVR valves, and they need a coronary procedure. And you can argue it's not an issue. No, I have no problems, but it's just not completely honest, because if you have to deal with a supraannular valve, coronary access is just way more cumbersome, or can be way more cumbersome. So I think that's a big argument when you talk about lifetime management. You have patients that come back with coronary artery disease, maybe even with acute coronary syndromes, but also if you talk about degeneration, you have to assume this patient needs a second procedure if you treat the 70 or 75-year-old patient nowadays. And you have to think about how you're going to put in a second valve in the valve that you're going to put in now. And taking all this together, I think there are a lot of arguments for intraannular valves.
So Dave, do you think it's fair enough to say there is somehow the promise to reconcile favorable acute hemodynamics with favorable reintervenability down the road?
Yeah, absolutely. I think it comes back to the fact that we've all been saying that it is not now acceptable to think about just the immediate procedure. We need to be planning for the long-term future of our patients. And clearly what we can't do is take any compromises. We mustn't compromise coronary access, as we've described. We mustn't compromise on hemodynamics for the future well-being and durability of the valve. So I like Fabian, didn't do an engineering part of my medical degree, and I'll admit my engineering naivety. What I think this does expose is perhaps our limited thought that the location of the leaflets is the predominant driver for hemodynamic function of the valve. Clearly, there are multiple factors at play, which include the design of the frame of the valve, the way that the commissures of the leaflets are attached to the valve frame and just not the leaflet location. So I think this is a good way for us to learn perhaps more about how we can benefit the long-term durability of the valves, not compromise on coronary access. And clearly I agree with Fabian that having an intraannular location of the leaflets facilitates future coronary access. And we have to be honest, we have to accept that bioprosthetic valves degenerate. We will need to revalve our patients. We will likely need to intervene in the coronaries of many of our patients. We can't afford the compromise. So I agree, we need to be looking forward for our patients.
Excellent. So I think we'll have to move on. Dave, why don't you take it from here and introduce the next topic that we're going to tackle?
Whilst we're talking about hemodynamics, we mustn't forget about what has previously been in a bit of an Achilles heel for TAVI, and that's paravalvular leak. Now, this was a seminal paper that's now 7 years old. This was from our echocardiology colleagues, and clearly we had already recognized pretty early that moderate or greater paravalvular leak increases both the risk of mortality and the risk of rehospitalization. Neither of those things clearly we want for our patients. That's all well and good, you might say. We're now in an era with more contemporary devices where we've largely minimized, if not eliminated, the risk of moderate or greater paravalvular leak. But that's not enough. We know that less than moderate paravalvular leak equally impacts survival. And clearly, if we are to provide optimum outcomes for our patients, we need optimal procedures that minimize the risk of even mild paravalvular leak. So luckily, we have a number of iterations of many contemporary TAVI devices. Navitor is one of those now, a contemporary valve on a contemporary valve delivery platform. And you can see some of the data. This is not randomized, it's all observational. This is from the original licensing series for all of these individual valves. So you can see now we do have the tools within our grasp to minimize the risk of paravalvular leak, which we know that even in mild or mild plus is potentially going to have an impact on our patient's outcome. So clearly we want to avoid this scenario. So I'm going to hand this over now to Juan, just really to talk about how we can do this and who are the people we particularly need to be minimizing paravalvular leak for.
Yeah, thank you very much, Dave. It's very important. And I think there's overwhelming data, and I don't need to repeat it, that there's a negative impact of moderate paravalvular leakage and even for mild paravalvular leakage. So I think it's really important to mitigate the risk whenever we can, right? And I have been thinking of who are the patients in my daily practice where I would really like to avoid the occurrence of any paravalvular leakage. And this is not backed up by evidence, but by gut feeling. And I'm open to discuss this. So I think that patients with no prior aortic regurgitation are more prone for these hemodynamic changes when they suddenly experience more AR. This is, I think, this is common sense. And I would be afraid of patients who have reduced LV function, that they have worse LV remodeling. And I have also seen patients with pre-existing MR and TR that due to the volume challenge, that this might lead to worsening of those MR and TR. There is some evidence that patients with PVL might develop anemia, which itself may impact long-term outcome. The mechanism has not been explained, maybe due to hemolysis. I think there could be a role. And I would like to show you a case that I have that in daily practice might be underestimated, which is, I think that this is of course a very extreme example of coronary malperfusion. If you look at the right coronary artery, you can see that the contrast doesn't reach the distal part of the right coronary artery. And this could be something like a seal phenomenon. And after postdilatation, you see that the right coronary perfusion is a little bit better, but of course we were not sure that there was not a spontaneous embolization, and we did selective angiogram of the right coronary artery. So these are the scenarios where I would try to avoid relevant PVL.
Brilliant. Yeah, it's a very good point, and I like the last point that we perhaps underappreciate the coronary perfusion with patients who've got paravalvular leak. And I guess, as you say, we now have variety of options for reducing paravalvular leak, so we are in a better space than we were perhaps previously. And I guess in terms of your experience, if you look at now some of the contemporary valve platforms with iterated valve sealing, my personal feeling is we seem to be getting rid usually of moderate leak now, and we're left with either none or mild, and we've seen some of the data for that. Is that something you see in your practice as well with the more iterated valve designs now?
Yeah, I absolutely agree. It is extremely important, and I mean, we are talking about lifetime management, and I think this is the word of the year, because we are talking about lifetime management all the time. All sessions are, the keywords are lifetime management, and I think it's extremely important to think about future coronary access gradients, etc. But we should not forget that the primary goal has to be that we have a safe procedure, and that we have to try to eliminate PVL that's more than moderate. But because I think those patients with moderate or more severe PVR, they won't survive to a longer term. So it is extremely important. I think we should be careful when we look at the data, because it really depends also on the calcium load and distribution. There are still patients outside that have such asymmetric calcification, maybe bicuspid with complex aortic root, that you won't be able to address with a TAVI valve. So we should be careful. There will be a small percentage that probably we cannot address, and that should be left up to the surgical colleagues. But other than that, I agree that technology has improved in such a way that in most cases, in most straightforward anatomies, we are able to reduce moderate PVL close to zero. That's correct.
And Fabian, I'm going to address this to you now. You're a relatively new user of Navitor. What have you found in terms of, you're a very experienced TAVI operator with multiple devices. What is it that's attracted you to Navitor?
Well, you know, nowadays you want to go into a procedure and you want not to experience any surprises. And to be perfectly honest, you just go nowadays with the valve that you have most experience in. You can treat probably 90% of your patients. But I felt that there are some advantages that I like about the Navitor platform that I think that are very attractive. Self-expanding, intraannular, large cells, that allow access to the coronaries, and the data showing good hemodynamics. So I told myself, well, this would be a good adjunct to my portfolio. And so I started again. We did a huge amount of portico in the past, and I have to say I was really surprised by the advantages and how you can handle this valve now. It's super stable. There are really no surprises whatsoever, and fantastic sheath, inline sheath, very smooth transition of the aortic arch. So this was my first experience, and I said this is really a valuable adjunct to my portfolio, given all the features I mentioned before. And I would like to say in this regard that it also makes sense not to just rely on one platform, but to have the options of I would say at least 2 platforms, because in the old days, as we said before, you wanted to eliminate paravalvular leaks, so you made the valve as big as possible. Now, the technology has become so good that even if you put in a way too small valve, you won't have massive paravalvular leaks with all these sealing technologies. So you don't want to compromise too much, and I felt that this platform gives me the option to not compromise on any of the important points that I mentioned before.
Brilliant, thank you. Okay, let's resume our role with Leonard as the heart team discussion for this patient. So remember, we've got our young patient, small anatomy, we've got some left ventricular outflow tract calcification, we've got good iliofemoral access here. So anyone for surgery?
Well, in that particular patient that we showed, 72, on the verge of being obese, right? It's a BMI of 30, and I remember some orthopedic issues also. Guys, why should we do open heart surgery, right?
Well, I think maybe taking a step back, first of all, it's a good message for us and for the patient that we do have both options, because this patient is far from being inoperable, that's for sure. Yeah? So you could offer both, but if you can, with a low risk, with a low procedural risk, you can start thinking about other endpoints, if you want to call it that. What about recovery time? You mentioned the reduced mobility, and it's true. She was mobile, but somewhat limping along, if you so will. You can think about hemodynamics. I don't think you could get away with an isolated aortic valve replacement. From my experience, these smallish, little overweight ladies do have somewhat hostile aortic roots for putting in a good-sized valve. So overall, I think she does have more than that one option.
Okay, so let's assume we all agree that a TAVI procedure is going to be a low-risk and effective treatment for this patient. Clearly, we have a choice of valves. In the end, the heart team here decided that a Navitor, because of the features we've described, excellent hemodynamics, single-digit mean gradients, excellent paravalvular leak data, and easy re-access to the coronaries for this young patient, was a very good choice for this patient. So for those of you who perhaps aren't so aware of the Navitor valve, as you can see, it is a large cell design optimized for easy, facilitated coronary access. We have this outer active sealing cuff called the Naviseal cuff to minimize the risk of paravalvular leak. We have now some optimized radial force across the whole size range. As we heard from Lars Sondergaard earlier in the day, that means both opening force as well as anchoring force. And we have a range of sizes currently available. We also have an excellent delivery system, this FlexNav delivery system, which is flexible, both at the capsule, hydrophilically coated behind that with an inline sheath. So this now enables access down to very small, tortuous, difficult iliofemoral as well as aortic anatomy, and we also have the ability to reposition the valve should we not be happy with the original position that we've generated. So what I'll do, I'll hand over now to Leonard just to really show the case that Leonard can narrate for the benefit of the audience.
Okay, thanks. So maybe while we bring up the second PowerPoint presentation where the case is included, can we have a polling in the auditorium? Who would go for TAVR?
Guys, don't embarrass us.
So I can't vote because I'm giving it away otherwise. Anyone for surgery?
Well, I think a game changer would be coronary artery disease. You know, this patient doesn't have coronary artery disease, but if someone has relevant coronary artery disease, is diabetic, etc. I mean, as you mentioned before, surgery is not out of the game. So surgery is an option, and I think in the future, coronary artery disease should play probably a more important role in the decision making. But I think what we've learned is the lower the risk, the more benefit comes out of transcatheter valve replacement.
Very good. So I have to admit we weren't quite sure in the heart team ourselves. There were pros and cons to both approaches. So we thought what would be more obvious than ask the patient. We've talked about small annulus and reduced mobility. This would speak for the lighter transvascular endovascular TAVR procedure, but patient wish does play a role. We've even more emphasized it even more in the guidelines. And on a side note, surgeons like to think that guidelines were like laws, but that's not the case, right? They're guidelines because they guide us, but it's not like it's a law. And the patient wish, even if it goes against evidence, if it's an informed consent, is also valid, I think. So this was a kind of a nervous kind of
maybe if I can make a comment,
absolutely,
but it's not acknowledged by German insurances.
Yeah.
The question is, what is better for our patients, guys, to be honest? Like, we can put these valves without intubation. The patient is awake. They look at the evening after the procedure, and we did dozens of Navitors, right, Elias, in the last year. They look as if they can go home the next day. What would be the advantage? I'm not joking. What would be the advantage of doing open heart surgery nowadays, unless we see that these valves are breaking apart after 2 years, or there is like a major damage to the patients? We need to do TAVR procedures in almost all of them, unless they are not good for TAVR. She is an excellent patient for Navitor. I vote for Navitor in all of these patients.
Maybe one question, Leonard. I think in these decisions, in these borderline cases, it's extremely important to take into account the anatomy, the patient-specific anatomy, and this is a major driver of the decision whether to do TAVR in younger than allowed patients. So the age cutoff is 75. Did you expect a good outcome with there is some kind of classification?
Well, yes. So I think from starting from the annular level, this was a moderate kind of calcification. It was not overly eccentric. So I think this was on the more doable side. There was some subannular calcification, but not the kind of aggressive, bulky LVOT calcification where you could envision that there would be a deficit in sealing. So overall, I agree to what Danny said. It's not picture perfect, but it's very, very acceptable. And I think if you did gather some experience with the modern sealing featured valves, more than doable, I think.
So nothing that the sealing cuff could not
handle. Yes.
Handle, yeah.
Yeah.
We've got an excellent question from Luca, our chat master, who promised us some searching questions he's provided. So I'll put this to the panel. Should we include information about durability of SAVR versus TAVR when consenting the patients and discussing within the heart team? Danny, if I start with you.
Well, obviously, we need to talk about it, and the younger the patients, like an 88-year-old, it would never come up as in discussion, but for 72, it must be part of the discussion. They need to understand the truth that we do not know. We do not know what will happen, not in 15 years, but in even 5 years. And it could be that we will see that there will be differences between some of the TAVR valves that we implant. Some of them are the valves that we implant commonly and for years, not only Navitor, that we don't really know what will happen in 10 years. We don't know. But we can assure patients that we think about the next procedure. That we will not just do the procedure and say goodbye, but we have a plan also if that valve will fail. This is how I see it.
Absolutely, and I don't know how you guys feel, but in my experience, if you confront a patient and tell them you could have surgery and maybe statistically and from the evidence base, the likelihood that this will be your one and only valve intervention is a little higher, even though it's not absolutely certain in these small annuli, or we could, do an awake TAVR, have you walking the ward next day, but you may come back for another one of these lighter procedures. Many patients will opt for, the second option to avoid the heavy surgical insult. And, if it's the patient wish and you've consented on that basis, I think it's very justified.
Unless, Dave, you say, it's a 45-year-old, let's put maybe a mechanical valve.
Absolutely.
And then if they are okay with anticoagulation and all that, and then maybe you say, okay, no need for re-interventions, but this is a different story. I don't see a lot of future for open heart surgery biological valves, to be honest.
Okay, so this is an extremely interesting discussion. We could probably go on forever, but we'll have to stick to the time a little bit and go into the case. This is just to show we did pick a TAVR according to everything, or according along the lines that have been discussed. This was fell right into place for a 25 valve Navitor, and this is the case we did. Awake, of course, local anesthesia only. We like to do it unilateral femoral puncture only, and bring in the diagnostic pigtail via the right radial to avoid contralateral femoral complications. You see the pigtail sitting in the non-coronary circumference of the root, valve passage. We like to determine invasively or confirm the diagnosis of severe aortic stenosis, which undoubtedly I think is present. This is being done with a dedicated TAVR stiff wire, and since this is an inline sheath, we need a 14 French in order to pre-dilate these valves. I like to pre-dilate most of the valves that I follow up with the Navitor in a brief phase of rapid pacing, which is usually very well tolerated by patients. This is the flex nav. You see the inline sheath right here. It's a very nice, smooth transition zone to the actual implant catheter with a nicely tapered tip, and it slides in easily, to my experience, as Danny and others have said, even across tortuous anatomies, even across small caliber vessels. Also, it travels very nicely across the arch due to the flexibility of the system, even the capsule housing the valve. Now, before entering into the annulus, I like to switch to the cusp overlap view in order not to have the valve stick in the annulus overly long when maneuvering the C-arm. And then from now on, I will see the hemodynamics in just a second. I think this is really exceptional, the kind of hemodynamic stability that you generate with this valve. You can discuss whether you need the fast pacing that we have here at all or no, but what you do see, and this is exceptional, as I said, I think in the self-expandable valves, there is very, very little hemodynamic compromise. There's no obstruction because it's intraannular, it's early functioning, it's very, very calm. Take your time, let the nitinol work its way inside the annulus. And then there's a two-step implant procedure, as we've said before. This is the first angio in the cusp overlap. I like to perpendicularize the stent in order to look at the left circumference of the annulus. And if we're confident here that the valve positioning is good, relax the wire a little bit, take all the pressure, all the tension out of the system, and very, very slowly deploy the valve. Release the outflow of the stent, take your time. Again, there's absolutely no need to rush it because there is no hemodynamic compromise, such as you might see in a self-expandable supraannular valve. And once the valve has left the capsule, look out for the markers in the outflow that you're really free of the implant catheter. And that's basically it. So I think for me, the major difference with other valve types is that the most crucial part of the valve implant, which is, if you want to, discriminate the procedure in little steps is the moment where the stent opposes in the annulus, extremely calm. There's no need to rush it, and you can take all your time. And this actually lends to the ability to work very exactly. You can be very courageous with your implant height, even more than this case maybe. You can land it at 0 or 1 millimeters. Anyways, once the valve is in, we do repeat the invasive measurement, good dicrotic notch here, good diastolic pressure separation. We've eliminated the stenosis, I think it's very obvious. And last part of the procedure for us naturally is an injection of contrast here with the good valve height, good coronary perfusion,
good result,
good sealing. So we're at the end of the case. And with that, actually, we're also nearing the end of the symposium. This is discharge. I'll complete this. Discharge day 6. Patients do recover quickly. You see the gradients here. No paravalvular leakage present despite that LVOT calcified portion of the subannular region. So I think from that perspective, we were absolutely satisfied with the result in this particular case. Good.
Excellent.
So we have a few minutes here. What are the things that we need to discuss? Dave, any thoughts? Maybe can I ask you, you had a lot of experience with the previous version, so the Portico valve, and you also are one of the leaders in the field with the Navitor valve. What, maybe if you want to point to one or two things, what are the major advances here?
Yeah, I think it's important to point out that this is now a contemporary valve platform. As with all devices, it's gone through iterative changes. So I think one of the big steps in improving the first generation Portico valve was the enhanced delivery system. For me, that miniaturized the vessels size that the valve could be delivered through. It also allowed for more predictable and accurate deployment. And we saw from the Portico ID study that changing the delivery system reduced the pacing rate, it reduced the rate of paravalvular leak. The journey has continued in that there's now a contemporary valve. The external sealing skirt, we've got near surgical-like results of paravalvular leak. We've got excellent hemodynamics. As we've all said, we've got continued easy reaccess to the coronary arteries. So this hasn't happened by accident. This has been a journey of iteration. And so now I would argue that Navitor is a conventional and contemporary valve platform. The other thing I think you showed beautifully in this case, it's an easy valve to use. It's so easy that even I can use it. And I think it's important. I think this is predictable. I think it's an easy platform compared to certain valve types. And I think that will be to the benefit of our patients' outcomes.
Okay. Danny, have you intervened post-Portico, post-Navitor? Any experience in the coronaries?
I did several PCIs after, not many, but several. And I mean, another aspect is that you can do commissural alignment also, which is part of the importance of doing a good coronary access afterwards. And the cells are quite large, right? So it's an intraannular valve, so not complex. But when I think about doing TAVI inside the failed Navitor, which will happen eventually, right? Especially when we do younger patients like the one presented, I think that it shouldn't be a problem just shoving in another valve. I don't see in many of these cases being at risk for coronary obstruction, which I see as an advantage.
Mm-hmm. Von, any thoughts on commercial alignment? I mean, people say, some people would argue intraannular, it's not as important, but, the field is moving. What do you think?
I think it's important to employ commissural alignment whenever we can. Mm-hmm. It's not only the height of the leaflets, but also the position of the commissural tabs, which might be a problem for coronary access. And I think we have to differentiate between having coronary access and being able to do a diagnostic angiogram, because it's a completely different story if you have to do any intervention. You need a completely different backup. So I think it's in our responsibility to create the best possible scenario for any following intervention. Yeah? And I would agree with you, the transition from the portico first generation, and I've done quite a lot of these procedures. I have also done a lot of proctoring, and it's a completely different story, I think. And to be honest, please don't get me, I'm trying to be honest, proctoring with the portico was quite a challenge. And proctoring with Navitor has become extremely easy, I think. So yeah, it's completely stable. It's yeah. Yeah.
No, I couldn't agree more. Are there any questions, by the way? We have an excellent panel here, so make use of it. Any questions from the audience, whatever topic? Anything in the chat, Dave?
There was one question about durability data, portico Navitor. Clearly, we don't have long-term Navitor data. We're out in most of the centres who are in the approval study to 2-year data, but we've only published out to, or presented out to 1 year. We currently have 4-year data through Portico 1. We'll have 5-year data next year, and you won't be surprised to learn that these good hemodynamics are translating to a low rate of structural valve deterioration. But as with all valves, we need longer term follow-up. That will be coming. The signal so far is good. We don't see a signal of a high instance of structural valve deterioration. So the story, I think, is consistent with the hemodynamics we've been discussing, but clearly we will want to see year on year the data published and presented, and that will come.
Okay, very good. So we're nearing the end. Maybe one last conclusive statement. I think what we're seeing now with this valve platform is the promise of reconciling an easy-to-use, very predictable, very steerable, very user-friendly device, which offers good hemodynamics acutely, but which also preserves the landing zone for further interventions down the road, enabling coronary intervention due to the large cell size and intraannular valve design. So I think I agree that we'll need to watch out for data coming in, but we have a very promising valve platform in our hands as an additional option maybe. Okay, so I'd like to thank all of you for your great contributions. I think we had a good discussion here. Thanks all of you for being here. Have a nice rest of the Congress. And once again, thanks for Abbott for organizing this.